So the important thing about diabetes is that it's a lifelong condition, all right? And the treatment of diabetes is as much with the patient as it is with the doctor.
Maria is a 50-year-old teacher. She's come into the diabetic clinic for the first time.
You're a teacher, you understand the importance of education.
Yes.
And we know that with diabetes, the more you know about the condition, the easier it is to control your sugar. Okay.
She had been feeling unwell and went to the emergency department. A blood check showed that her sugar was high at 340 milligrams per decilitre, so she was told to come to the next diabetic clinic.
Most of the times I could feel thirsty, dizziness, and drinking a lot of water. Sweating, maybe during night, and going to the toilet frequently.
Okay.
Most of the times I could feel numbness.
Okay. That numbness is also because your sugar is high at the moment.
These symptoms are typical of someone with high sugar in their blood. Too much sugar in the blood dries the body out. The body tries to expel the glucose in the blood through the kidneys into the urine.
The reason why you pass a lot of urine is that sugar exerts an osmotic pressure. Glucose has an osmotic pressure. So when it's filtered in the kidneys, it passes into the urine, it draws water with it. So basically you pass large amounts of very sweet urine and your body becomes dehydrated. And the thirst is a corrective mechanism to make you drink more to try and compensate for the dehydration. The dizziness comes about because you have a low blood pressure because you're dehydrated.
Passing high volumes of urine, thirst and dizziness are the most typical symptoms of high blood sugar levels. But there are others. People often feel tired. While many type 2 patients are overweight when first diagnosed, if their condition continues untreated, they'll start to lose weight. Another frequent symptom is for vision to become blurred. Blurred vision is usually due to the effect that high blood sugar has on the lens of the eye. The lens is the part at the front of the eye through which light enters. A newly diagnosed patient whose sugar has been high for a while will often have blurred vision. But it can also affect patients who've had diabetes for some time if their blood sugar is too high for a few days. The important thing is that changes in the lens of the eye are reversible. Once the blood glucose is controlled, it usually takes about 6 weeks for the eyesight to return to normal. If the vision does not become normal, then there are several possible explanations. It may be that the blood glucose levels are still high, so these need to be checked. If, on the other hand, the patient is controlling sugar levels well, then it's important to get a proper examination from an eye specialist, because the blurred vision could have other causes, such as cataracts or diabetic retinopathy. Cataracts and retinopathy are more serious, but both can be treated as long as they're recognized early enough. Another common complaint of patients with newly diagnosed diabetes is numbness or burning pain in the feet. Again, this can be caused by a reversible short-term effect of high sugar levels. So, in most newly diagnosed patients, it improves as the diabetes comes under control. But if it does not improve, once again, it may mean that the patient has a more serious long-term complication called neuropathy. Neuropathy develops when there's damage to the tiny nerves that carry sensation from the skin to the brain. It can be caused by diabetes itself, by poor nutrition, or as a side effect of some medicines. Neuropathy is a long-term complaint that is often irreversible. Neuropathy and the other long-term complications of diabetes, such as damaged blood vessels in the eyes and kidneys, usually develop when a patient has had diabetes for several years. But they can also be present when someone is first diagnosed. In type 2 diabetes, symptoms can be quite mild and may go unrecognized for several years. So, newly diagnosed patients with type 2 do need to be checked for long-term complications like neuropathy, nephropathy, or retinopathy. Infections can be another possible clue when diagnosing diabetes. Infections on the feet are quite common and become an especially serious problem the longer a person has had diabetes. Diabetes can reduce the body's immunity, opening the way for infections. These can be either fungal or bacterial. In addition, high levels of sugar in the blood and urine can create a culture in which bacteria and other infections thrive. Sometimes diabetes can open the way for much more serious conditions such as pneumonia or TB. However, be aware that the symptoms associated with diabetes can have other causes. There are other conditions that can cause frequent urination. Other conditions also lower the body's defences, opening the way for secondary infections. Knowing someone's HIV status is particularly important. When diagnosing diabetes, the symptoms by themselves are never enough. If typical symptoms are present, they must also be accompanied by at least one abnormal blood sugar measurement. If no symptoms are present, then there must be 2 abnormal blood glucose measurements. There are 2 ways of measuring blood sugar levels. If you just take a random blood test any time of day without taking into account what the person has eaten, the results can vary a lot. This is called a random blood glucose level. It should be below 200 milligrams per deciliter of glucose. A much more accurate way, which is used at diabetes clinics, is to ask people to have a blood test first thing in the morning, so that they've eaten nothing for at least 12 hours. This is called a fasting blood glucose level. This should be below 126 milligrams per deciliter of glucose. Sometimes the measurement of milligrams per deciliter is replaced by millimoles per litre. Multiply millimoles per litre by 18 to convert them to milligrams per deciliter.
Right. But in addition to that, your sugar is really quite high.
Maria's fasting blood sugar is 340 milligrams per deciliter. This is very high. So with a 6-month history of typical symptoms, a diagnosis of diabetes can be made straight away without further tests. When a patient like Maria is newly diagnosed with diabetes, the doctors looking after them need to decide if they have type 1 or type 2 diabetes. This is important as the treatment of the 2 conditions is quite different.
Pamene tiri kumwa mankhwala shuga tikhoza kumwanso mankhwala ena
ziko muwambiri akuti pamene kumwa mankhwala shuga tikhozanso kumwa mankhwala ena ndeti yankhe tikhoza kumweti ndeti yankhe.
In Malawi, more than 80% of diabetic patients have type 2 diabetes. Typically, type 2 diabetics are older and have had symptoms coming on gradually for several months. At the time of diagnosis, they're often overweight, and about half will have other family members with diabetes. A typical type 1 diabetic, by contrast, is usually a child, a teenager, or a young adult. They're usually slim and will only have been unwell for 2 or 3 weeks at the time of diagnosis. The symptoms are usually much more severe and develop very quickly. However, not all patients fit these patterns. Occasionally, it can be difficult for the clinician to decide which type of diabetes the patient has. A urine test to look for ketones can be helpful. A type 1 diabetic usually has a high level of ketones in the urine at the time of diagnosis. Maria is very typical of a type 2 diabetic who's developed diabetes in middle age, and in her case, there's no doubt about the correct diagnosis. Type 2 diabetes is sometimes more complicated to recognize and manage than type 1. This is because it can have several different causes and may vary a great deal from person to person. Remember that it's the pancreas which produces insulin, the hormone the body uses to process sugar and turn it into energy. In type 1, the pancreas fails and stops producing insulin. In type 2, by contrast, the pancreas often continues to produce insulin, but the insulin stops working. When the insulin reaches individual cells, particularly in the muscles, it should work like a key. It's the insulin which unlocks the doors of the cells, allowing them to refuel with sugar. In type 2 diabetes, the key simply stops working. This is called insulin resistance.
I've used this term insulin resistance. It means the tissues of the body respond less well to the insulin that's produced by your pancreas. And insulin is necessary to move glucose from the bloodstream into the cells to provide the cells with energy. So if your tissues are resistant to insulin, it makes diabetes. Your sugar remains in your blood and it doesn't move into your cells. So you have the same problem, too much sugar in the blood, not enough energy in the cells, but it's not as severe as type 1. Now what happens with type 2 as time goes on is that the pancreas actually does fail. So the amount of insulin that's being produced gets less and less as the years go by. And eventually, even a type 2 diabetic will need insulin injections.
Type 2 diabetes can have several different causes. Often it's genetic. Maria doesn't know of family members who are diabetics. This is unusual, as type 2 diabetes often runs in families.
The genetic risk for type 2 is much stronger than type 1. So if you look at our diabetic clinic at Queen's, half of our type 2 patients have a relative with diabetes. And then there is an environmental trigger, and the environmental trigger may be something like becoming obese, doing less exercise, or taking some drugs, such as ARV drugs or corticosteroids, and that combination leads to diabetes.
But being overweight can sometimes also be the principal cause of diabetes. Let's have a look inside the body again to see the impact of excess fat. Fat is also carried around the body in the bloodstream. Outside the cells, the body has a mechanism to break the fat down to use it as energy. But if there's too much fat, then this mechanism gets overloaded and fails. So then the fat builds up around the cell, stopping the insulin key from working and stopping the glucose from getting into the cell.
Now, losing weight reduces insulin resistance. And theoretically, if you were very overweight and that was the main risk factor that you had for diabetes, if you lost enough weight, the diabetes could go away. And that has certainly been shown as a prevention strategy. There have been studies all around the world, although not locally, not as close as Malawi, but even in Kenya, that if you take people with pre-diabetes, which is in a condition of impaired glucose handling, but not true diabetes, and you start to introduce lifestyle measures at that stage, including exercise and weight loss, you can prevent diabetes. So weight loss is a critically important part, and if you already have diabetes, it will improve your glycemic control.
Maria is badly overweight. Regular weighing is very important because being overweight makes controlling sugar levels much more difficult, seriously adding to the risk of complications. One of the main ways that overweight diabetics can help themselves is by losing weight. However, once again, there's no firm rule. Some type 2 diabetics, particularly those with a high genetic risk who are not diagnosed early, will lose weight dramatically and may become very thin. This is because the cells of their body are not getting the sugar that they need. It's important to know the body mass index or BMI of a diabetic patient because this will be used to make decisions about treatment. This is worked out by comparing both weight and height. Maria weighs 96 kilos and her height is 162 centimeters. This means she has a body mass index of 36.6, which is obese. A BMI of 20 to 25 is ideal. Less than 20 is underweight. 25 to 30 is overweight. More than 30 is obese.
So this will be one tablet in the morning, one tablet in the evening. All right?
Treatment decisions need to be made by a clinician. However, it is useful for people with diabetes to understand how the doctor or clinician reaches a decision.
And I don't want to see you for 3 months. All right? We don't see our diabetic
For type 2 patients, the treatment that's started is based on initial blood glucose levels and BMI. The first decision that needs to be made is whether they're managed with diet and exercise alone or whether they also need medication. If the initial pre-treatment fasting blood sugar level is less than 300 milligrams per deciliter, then they should start with diet and exercise treatments only. If the initial pre-treatment blood sugar level is above 300, then a patient will need to start tablets as well as diet and exercise. The next decision is which tablets to start. The tablets do not put insulin into the body in the way that the injections do. Rather, they stimulate the pancreas to produce insulin, or else they make the cells more receptive to insulin and so increase its effectiveness. If someone's BMI is less than 25, they should start glibenclamide. Whereas if they're overweight or obese, they should start metformin. This is because metformin has the added advantage of helping them to lose weight. The doses of these drugs depend on the blood sugar level. If the fasting blood sugar is between 300 and 400 and the BMI is less than 25, they should start glibenclamide, 5 milligrams, once a day. If the BMI is more than 25, they should start metformin, 500 milligrams, twice a day. If the fasting blood sugar is more than 400, the doses of these same drugs should be doubled. Sometimes these values are given as millimoles per litre. These are only the starting treatments for these patients. Most patients will need increased doses at subsequent clinic visits, as well as changes in diet and lifestyle to bring fasting blood sugar levels down to the target range of less than 130 milligrams per decilitre.
We can give you Manquala, but the Manquala won't work for you unless you also change your diet, the food you eat, and do more exercise. All right?
It usually takes 6 months or more to stabilise someone with type 2 diabetes. Once treatment is started, it's normally for life and should not be stopped. Otherwise, the diabetes will go out of control.
What you need to know for yourself, and also what is it?
So, what treatment should Maria be given? She has a fasting blood sugar of 340 and a BMI of 36.6. Because Maria's blood sugar level was more than 300 but less than 400, the decision was made to start her on tablet treatment as well as diet and exercise. She's obese and therefore is started on metformin, 500 milligrams twice a day. And she's advised to come to the diabetes education sessions. However, treatment of high sugar was not the only priority for this visit, because Maria also had high blood pressure. This puts her at increased risk of a stroke, a bleed or clot in her brain, or damage to the small blood vessels, which can accelerate the complications of diabetes. 50% of diabetic patients also have high blood pressure. The target blood pressure for diabetic patients is to be less than 130/80 millimeters of mercury.
So your BP is 162/96. Okay. Now this is a bit too high for a diabetic. All right. What we want, your target, is for this to be less than 130/80. All right.
Maria is already on treatment for her blood pressure with hydrochlorothiazide or HCT. But this is not sufficient to control it.
I won't change your tablet today.
Okay.
But what you need to do is see if there's anything you can do again with your diet. And in fact, if you're losing some weight and doing more exercise for the sugar, that will also help the BP.
Okay.
All right. Do you take much salt?
No.
Not much. Okay.
Just
I
a
know
bit.
many Malawian people love salt. Yeah, that I've learned. More than sugar, they like salt. So we need you to really try to cut down salt from the diet.
Okay.
All right. And what about?
After this first visit, we decide to leave her medication for blood pressure the same, but emphasize the need to cut down salt and avoid painkillers such as Brufen, diclofenac and indomethacin. If she manages to lose weight and exercise more, this will also help her blood pressure. Finally, she's recommended to take a quarter of an aspirin every day to reduce her risk of having a stroke. This is because she has 3 major risk factors for stroke: her age, her diabetes, and her high blood pressure.
So I'm just looking here at your sugar value compared to last time. So last time, when you came to us the first time, your sugar was 340, which is really quite high. And you've shown good improvement. It's come down to 220. Where we want it to get in the end is down to 130. So there's still a way to go.
Yes.
but you're making good progress.
Okay.
All right, and you've lost a little bit of weight, which I'm sure is helping you.
Thank you.
Are you doing more?
3 months later, Maria has come back for a follow-up. Her blood sugar has improved, but is still at 220 milligrams per decilitre. So a decision now has to be made whether it should be adjusted.
There are two things we could do. We could say, well, your sugar has really improved quite well. It's still got to continue improving.
Okay.
Do you think there's still more ways you can improve your diet? Do you think there's things that you could still do to get better?
Yes, from the diet.
From the diet side, do you think there are still changes that you can make?
Mm.
We can do that anyway, but in addition we can give you a stronger tablet of metformin,
Okay.
which will just help that along. And I think probably the thing to do is both.
Okay.
So you keep working on the diet and we'll
Mhm.
give you a high dose of metformin.
Okay.
All right?
Okay.
The other thing is with your BP, because it really has not changed very much. And you said that you were not taking Brufen, you were already having low salt, so I'm not surprised. And I think it's important that we increase your blood pressure treatment.
Okay.
All right? One of the things
The other area of concern is still the blood pressure. Maria's blood pressure is 155 over 90 millimeters of mercury. This is better than last time, but it's still a long way from the target of 130 over 80.
So when we treat sugar, we always also treat BP, okay? And we want you to have a very good blood pressure.
Okay.
Just going to have a look at your feet. Can you take your shoes off? When you have diabetes, it's very important that you take good care of your feet.
Yes.
All right, you've probably heard that diabetic patients can get foot problems.
Maria needs to know at this point about potential long-term complications of diabetes. She needs screening to make sure she doesn't already have a problem with her eyes or kidneys, and she needs to know what to look for in her feet. At the last visit, she had some numbness in her feet and blurred vision. These have now both improved and were probably due to the high glucose rather than long-term complications of diabetes. Complications generally do not improve without specific treatment.
It's got a bit of an infection on the nail, hasn't it?
Yeah.
And the nail has actually come off, hasn't it? This is usually due to a fungal infection. It's easy, lots of people...
Maria has several things which could cause problems in her feet. She has an infection on her toe, probably a fungal infection. And there are patches of dryness. These all need to be addressed.
There's a little bit of dry skin here. You need to make sure that you keep the skin soft, all right? After you've washed them, dry very well, dry between the toes, and rub some oil into the skin. Because dry skin like this can crack, and if there's a crack in the skin, that's how infection enters, and that's how the wounds that diabetics get begin. Okay. Let me just ask you one other thing before you go. Have you ever had an HIV test?
Oh, yes.
When did you have your test?
It was last year.
Last year. And how was the result?
Negative.
Negative, okay.
Finally, she needs to have an HIV test. It's very important that all diabetics know their HIV status, because otherwise it makes it much harder for the clinician to make the correct decisions.
It's very important we know about that. And last year is a long time ago. Things can change. So can I ask you, before the next time you come and see us, you go for a new HIV test?
Okay.
All right?
Maria will continue to need checkups, and it's important that clear notes are taken and a good history is built up over time. Type 2 diabetes is usually a progressive condition, as the body gradually loses its ability to process sugars. Having a good history is vital to being able to make the correct decisions in the future.